is Dr. Cynthia Mag. I'm the Director of Genetic Pathology for Weill Cornell Medicine. Welcome to our case presentation in genetic pathology. So the case we'll present today is that of a male patient who has long-standing hair loss that commenced at age 21. It's followed this progressive and insidious course over the decades, and now at age 68, the patient is presenting for a biopsy to determine the etiology of the hair loss. We have two types of biopsies in this case. We have a horizontally sectioned scalp biopsy and a vertically sectioned scalp biopsy. So at the most distal part of the horizontally sectioned scalp biopsy in the fat, normally one expects to see a number of terminal hairs, usually on average in a Caucasian patient around 35, African American around 20, and patients of Asiatic extraction around 15. And so here in the fat there really are no discernible hairs, which would certainly correspond with a state of fairly advanced alopecia. Now as we section the hair more proximally, in the mid part of the scalp biopsy, we see follicular units. The follicular units are composed of 2 to 5 hairs, and in a 4 millimeter horizontally sectioned scalp biopsy, there are around 12 follicular units, roughly per 4 millimeter section. So here, the number of follicular units are more or less within normal limits. The number of hairs range from 2 to 5, so also normal. But what is remarkable is the fact that most of these hairs are miniaturized. They have a vellus type appearance. The sebaceous glands are intact. There's not much in the way of inflammation, so there's also no evidence of any type of a concurrent inflammatory or scarring alopecia. So this is just a higher magnification of one of these follicular units, and you can see that most of the follicles, in fact all the follicles in this follicular unit, have a small miniaturized vellus type hair appearance. In other words, the actual hair shaft, which is right here, is about 30 microns in diameter, being of lesser diameter than the combined Huxley's and Henley's layer, which constitutes the inner root sheath. And unlike a true vellus hair, which is that peach fuzz on our facial skin, there are sebaceous glands because they represent basically a conversion of terminal hairs into these miniaturized vellus type hairs. This is the vertically sectioned scalp biopsy, and it basically shows the same fundamental process as what we gleaned on the horizontal section scalp biopsy, which is that the hairs that are present are smaller hairs situated in the superficial and mid dermis. Sebaceous glands are intact, there is no inflammation, so it is a non-scarring alopecia where the alopecia is attributable to this type of vellus type hair miniaturization. So to summarize then, there is significant hair miniaturization. The majority of hairs are vellus type, not true vellus hairs, again because of the association with sebaceous glands. Most of the hairs in a scalp biopsy, around 90%, normally are anagen hairs, around 9% are telogen and 1% are catagen. In this particular case, the percentage of telogen hairs was around 15%, which would be indicative of a very mild involutional tendency. No inflammation or scarring, so a diagnosis was rendered of advanced androgenetic alopecia. The basis of androgenetic alopecia is the transformation of terminal follicles that produce large, thick, pigmented scalp hairs into smaller vellus follicles that produce short, fine, colorless hairs that can start to become apparent as early as puberty. The basis of androgenetic alopecia is the transformation of terminal follicles that produce large, thick, pigmented scalp hairs into smaller vellus hairs that form short, fine, colorless hairs that can start to become apparent as early as puberty. Paradoxically, one of the cardinal hallmarks of puberty in adulthood is the transformation of vellus hairs into terminal hairs involving the face, axilla, genitalia, and chest. So it's not uncommon to see men that have very advanced androgenic alopecia have a very robust beard and chest hair. So the androgens have these selective effects on scalp hair versus other types of hair on the body. So the average anagen cycle, which is the growing phase cycle, is a couple of years. And in fact, in some patients, it can be as long as 7 years. The average duration of the resting phase or telogen phase is about 100 days up to 6 months. Normally, the anagen to telogen ratio is around 9:1, but as the anagen cycle duration is reduced in androgenetic alopecia, there is a progressive reduction in the anagen to telogen ratio, such that in classic androgenetic alopecia, the anagen to telogen ratio is less than 4:1. There can be some overlap with senescent balding, where over the age of 50 there is a progressive decrease in the overall number of anagen follicles. In men, the hair loss is oftentimes like a patterned hair loss, where they start with temporal regression, it spreads backwards, and then ultimately they get significant thinning on the vertex. And that type of pattern hair loss falls into the Hamilton classification. Women who have androgenetic alopecia oftentimes have a very diffuse pattern of alopecia, and that diffuse pattern of alopecia is referred to as the Ludwig diffuse pattern. So what is the baseline histology? The overall hair density in the superficial dermis is preserved, around 35 in Caucasian, 20 in African American. But the hair density in the fat, which is where you find those big terminal hairs, is decreased. As I was mentioning, the anagen to, or the terminal to vellus hair ratio is typically less than 4:1, and there is a slight involutional tendency, not to the magnitude that one sees in alopecia areata, for example, where there is also hair miniaturization and involution, but the involutional tendency is so much greater. This is another horizontally sectioned scalp biopsy from somebody with androgenetic alopecia. And the main issue here is that there are a number of terminal hairs. I think the overall density is somewhat decreased. But the key is the variation in the hair follicle diameter. The fact that you do have this significant variation in the diameter of basically terminal hairs is an important clue regarding a diagnosis of androgenetic alopecia. And this, again, is your vellus type hair, which is ultimately the basis of androgenetic alopecia, is an increased number of these miniaturized hairs that are derived from the terminal hairs, reflective of the reduction in hair cycle. And this is a hair follicular unit, which here is composed of 4 hairs, and all 4 hairs are small vellus type hairs. And in the deeper dermis and subcutis, there is a marked reduction in hair density, which is due to a decrease in terminal hairs. The arrows are pointing at fibrous streamers, which reflect the collapsed connective tissue sheath in association with the now miniaturized vellus type hair. In early androgenetic alopecia, it is quite common to see a lymphocytic infiltrate in the bulge epithelium of the hair follicle, which is the sort of lower isthmic part of the hair follicle. And that lymphocytic infiltrate in and around the bulge epithelium, which also houses the stem cells for the hair follicle, may play a role in accelerating the hair cycle. At times, androgenec alopecia does coexist with other types of alopecia, like chronic telogen effluvium and central centrifugal cicatricial alopecia. So in this particular field, we have 3 hairs, and 2 of the hairs are telogen germinal units. So there is both hair miniaturization and involution, and this patient had concurrent androgenetic alopecia and chronic telogen effluvium. We know that androgens are integral to the pathogenesis of androgenetic alopecia. Men who do not undergo puberty never develop baldness. Men who have androgen insensitivity because of lack of functional androgen receptors do not develop baldness. Overall, we know that normal male androgen levels are sufficient to cause androgenetic alopecia. What about the pathophysiology specifically? I mean, how do androgens actually cause that shortening of the anagen hair cycle? Well, testosterone becomes dihydroxytestosterone via alpha reductase. The interaction between that testosterone derivative with the androgen receptor within the actual mesenchymal body of a terminal hair, or the so-called dermal papillae of the terminal hair, presumably is key to the acceleration of the hair cycle. It may reduce the signaling that provides ongoing stimulation to maintain the anagen phase. It could also lead to an acceleration in the mitotic activity within the anagen hair bulb, resulting in a shortening of the cycle. There's no question that it is that interaction of dihydroxytestosterone with those androgen receptor positive mesenchymal stromal cells in the hair papillae of the terminal hair that seems to be key in the pathogenesis of androgenetic alopecia. And this, in fact, is a cross-section of a terminal hair. These small cells here are the bulbar or germinative epithelium that gives rise to the hair cortex, which in turn becomes the hair shaft and the inner root sheath. And in the center is the mesenchymal body, or the dermal papillae, and it contains stromal cells that show very strong nuclear staining with human androgen receptor. And again, it is the dihydroxytestosterone binding to these cells that somehow alter the dynamics of that anagen hair to accelerate its cycle, to result ultimately in hair miniaturization, which is the essence of androgenetic alopecia. Thank you very much, and as you know, the PowerPoint presentation is available for download for your study and use. Thank you.